So hi friends, a very good morning to all of you. I am Dr. Pankaj Tikku. I am a pediatric mentor for your FMGE exams. I will be taking the 25 most important clinical questions from pediatrics session today, and we'll try to see what are the important topics which are really important from your FMGE exam point of view. And from those questions, I've carefully curated these, from those topics, I've carefully curated these questions. So let us go through these questions one by one. Also note the important topics from which these questions have been taken. I hope I'm audible, I'm visible to everyone. Good morning, everyone. Good morning. Hope I'm audible, I'm visible to everyone. Should we start the session? Should we start the session? Yes, you'll all pass with flying colors. Good morning, good morning. Should we start the session? Audible, visible to everyone? Okay, so let me start the session. The first question that I have taken is a question which is from one of the most important topics of pediatrics for these FMG exams, and not only for FMG exams, it's one of the most important topics for NEET, PG and NICET also, and that is milestones. So this question is a normal child who is growing normally also and is developing normally also is brought to the pediatric assessment clinic. So the child is both growing normally and developing normally. And it's very important to know the difference between them. I've always told in my classes that growth is increase in the size of the child, while development is related to the brain development, milestone development. So both should go hand in hand. Both growth and development should go hand in hand for a child to be normal. So just growth of the child normal, development is not normal. In that case, the child is not normal. Similarly, if the development is normal, growth is not normal, the child is again not normal. So this is the child who is brought to a pediatric assessment clinic, and some of the milestones are shown in the child. He says which is the last milestone to develop in the child. So obviously, for answering these type of questions, you should be very clear about the milestones and the age at which these milestones appear. So as I'm seeing in the chat box, most of you are answering the question as the answer as C. So let us see what are the time periods in which these milestones given in the options develop. So the child mostly stands without support around the age of 12 months. So while the child can stand with support at the age of around 9 months, but the child can stand without support roughly by the age of 12 months. Similarly, a child can sit. The first option is standing with support. So the child stands with support at the age of 9 months, and the child can stand without support at the age of 12 months. So the first option is standing with support. So the child can stand with support at the age of around 9 months for the first time. The second option is sitting without support. So when are children able to sit without support? So most children are able to sit with support starting from the age of around 5 months to 6 months. By 6 months, they are sitting in a tripod position. While by the age of around 8 months, children can start sitting without support. Then most children can speak in jargons by the age of 15 months. So the child can speak in jargon at the age of 15 months, and most children can play with their mirror image by the age of around 6 months. 5 months to 6 months, children can play with their mirror image. So now if you see all the milestones that have been mentioned in the options, which is the milestone which is the last to develop in the child, the milestone that is last to develop in the child is C. So you are correct. The milestone which is the last to develop in the child is C. Very quickly, let us see what are the different milestones. So sort of a revision for you. So we'll see the different milestones which are gross motor milestones. And we'll also see the milestones, important milestones, which are the fine motor milestones. Then we'll see the milestones which are important language milestones, and some important milestones which are social milestones. So just a quick revision of these milestones. So in gross motor milestones, I've told you in my classes that most children are able to sit with support. at the age of around 5 months to 6 months. So by 6 months, they can sit in a tripod position, and most children can sit without support at the age of around 8 months. Children can stand with support at the age of around 9 months, and children can stand without support at the age of around 12 months. Children can walk with support at the age of around 10 to 11 months, and most children are able to walk without any support for the first time, obviously briefly only for a small moment of time, then they obviously will fall down, but they do start walking without support for the first time just after the first birthday, which is around 13 to 15 months. They will start climbing stairs from the age of around 2 years. Initial climbing of stairs is 1 step at a time, and then they can walk alternate foot per step, and by 4 years most children are able to go upstairs and downstairs maturely, alternate foot per step upstairs also and downstairs also. That is gross motor milestones. Please remember these gross motor milestones, they are important for your exams. Now coming to the fine motor milestones, the use of grasp. So most children are able to catch objects using both hands for the first time, voluntary grasp, but a bidextrous approach for the first time at the age of around 4 months. Then children can start catching objects using a unidextrous approach, one hand only, at the age of around 6 months. So 4 months they are catching objects with both hands, while 6 months they are catching objects with one hand, also called as a bidextrous approach and a unidextrous approach. That's the first time a voluntary grasp develops in the child. And by around 7 months, 6 months to 7 months, they are able to transfer objects also from one hand to another hand. Then coming to the palmar grasp, the initial palmar grasp is immature palmar grasp, and the first immature palmar grasp which develops is the ulnar grasp, which appears at 6 to 7 months. Now by 8 months to 9 months roughly, the radial grasp develops, which is catching objects using the radial aspect of the palm. The pincer grasp appears by the age of around 9 months, but the mature pincer grasp appears by the age of around 12 months. Then children can usually make tower of cubes starting from the age of around 15 months. So by 15 months, they can make a tower of 2 cubes. By around 2 years of age, they can make a tower of around 6 to 7 cubes, and by around 3 years of age, they can make tower of around 10 cubes. So 1 cube above the first cube. They start copying objects for the first time from the age of 2 years. So objects like line at the age of 2 years, so they can copy a line at the age of 2 years, they can copy a circle at the age of 3 years, they can copy a square or rectangle at 4.5 years, triangle at 5 years. So they are now copying objects. So important ones are the line 2 years, circle 3 years, square around 4.5 years, triangle around 5 years. Then they can make, and there are some more which I have told in my classes, I'm just telling you the important ones. Then most children are able to use the spoon and cup for independent feeding starting for the first time. Now they are using this for the first time at the age of 10 to 12 months, independent feeding, but obviously that is with spilling of most of the contents. Later on, they learn to use a cup and a spoon both without spilling the contents also. But at 10 to 12 months, they are eating using independently a spoon and a cup with spilling the contents. That is about fine motor milestones. Language milestones, now the first time vocalization and cooing develops is in the first 3 months. So the child starts to vocalize roughly by the age of around 1 month, and cooing develops by the age of around 3 months. Gradually, they learn to start speaking in monosyllables. Then they start to speak in bisyllables. So most children are able to babble by the age of around 6 months. By around 9 to 10 months, they start speaking meaningful words. So the first meaningful word that the child can speak is at the age of around 9 to 10 months. Gradually, their vocabulary increases as more and more meaningful words are added in the vocabulary, and mostly by the age of around 15 months, children starts combining these words, though in a jargon. So they are not still forming sentences, but they start speaking in jargon roughly by the age of around 15 months. And by around 2 years of age, most children start speaking in proper sentences. Gradually, they also learn to tell stories, but this is important milestones, language milestones that you should know for your exams. Now coming to the social milestones. Social smile develops at around 6 to 8 weeks. The child first recognizes the mother by the age of 3 months. A very important question. When does the child first recognizes the mother? That's at the age of around 3 months. Children gradually start to increase their social milestone criteria as they start trying different type of games. So they start standing in front of a mirror, playing with their image at the age of around 6 months. They gradually get accustomed to a peekaboo game at the age of around 10 to 12 months. They start even waving bye-bye by the age of around 9 months. And gradually they learn to identify objects also, identify their name also, all at the age of 3 years. They can identify colors at 3 years, they can identify objects at 3 years, they identify colors at 3 years, name identification 3 years. They become right-handed, left-handed. Again, a very important question and a past FMGE question. When do children become right-handed, left-handed? So children become right-handed, left-handed at the age of around 3 years. A complete bowel control develops by the age of around 4 years. That is why encopresis diagnosis is usually made after the age of 4 years. Encopresis is passing of stools, feces at places other than the washroom, the toilet. And most children are able to get toilet trained by the age of 4 years. So even after the child is not properly trained for passing bowel movements in a proper way, we call that as encopresis, and that is usually after the age of 4 years. Similarly, enuresis, bladder control. So bladder control develops at the age of 5 years, and therefore subsequently if the child continues to pass urine, then obviously you make a diagnosis of enuresis. So thank you, Risha. I watch your previous videos. Everything is from notes. That is a very big compliment from me. And I would recommend that you all please prepare your notes. Most of the things that we teach in the exams, please understand those are the things that are the most important things. So the probability is very, very high that you get questions from somewhere around those topics only. Well, no one is God, and we cannot become God. So obviously there are things that can be asked from outside topics also. But even if you get majority of questions from each subject, from what your faculty has told me, it would be a cakewalk to pass these exams. So please read your notes properly. The first line treatment for enuresis, as you have correctly pointed out, is the bell lamp therapy. Very important topic. First line treatment for enuresis in children is bell lamp therapy, which is also called as the behavioral therapy, bell and lamp therapy. And the pharmacological treatment is the second line treatment. And for the pharmacological treatment, the first line treatment usually is always desmopressin. So desmopressin, oral desmopressin is what we give as the first line pharmacological treatment of choice, desmopressin. And in case desmopressin is not working, then we might give anticholinergic options such as oxybutynin and tolterodine. There are third line drugs also, but I think this is what you should remember for your exams. Desmopressin, the first line pharmacological treatment for enuresis, and in case this desmopressin does not work, then there are anticholinergic agents such as oxybutynin, tolterodine, which can also be used. Obviously, however, they are associated with anticholinergic side effects. So those are things to consider when you are prescribing anticholinergic. So I hope you are all well done and well prepared from your milestone point of view. Have you all prepared from your milestone point of view for these exams? Please be very, very thorough with your milestones. This is one thing that you should always be very thorough. Subsequently also, I hope you all will be giving NEET PG exams. Then also these milestones will be very, very important. So I hope you are all thorough with your milestones and you have gone through these milestones properly. Now let us come to question number 2. Question number 2 says, some growth assessment markers are mentioned below. Which of these would be the most, which of these 4 would be the most valuable for diagnosing wasting in children? So there are 2 terms that I have given, wasting and stunting. I've told 2 terms in my classes, wasting and stunting. And it's very important to know the difference between them. See, as the name suggests, wasting is defined as an acute, sudden drop in the weight of the child. So the child is losing his muscle mass, he is losing his weight, and that has happened very recently, suddenly, acutely. But over a period of time, when malnutrition continues, and gradually height also starts getting affected. So now the child appears short for his height, and that is when we say stunting has started developing. So while wasting is more of an acute malnutrition marker, stunting is more commonly a chronic malnutrition marker. Now, when you are talking about markers of malnutrition, you use various anthropometric markers. For malnutrition in particular, we use these three markers: weight for age, weight for height, and height for age. These are the three main markers that are used when you are assessing a malnourished child: weight for age, weight for height, height for age, and obviously in addition to these you are also using some other markers such as mid-arm circumference, which can also support the diagnosis of malnutrition, whether it's severe, whether it's moderate. Primarily when it comes to stunting, for stunting, height for age is the best marker that can be used. Stunting, height for age is the best marker for use, because as I have told you just now, when you're talking about stunting, it means malnutrition has been occurring for so long that finally the child's height has also started getting affected. So in a nutshell, when malnutrition starts occurring in the initial phases of malnutrition, when the malnutrition is more recent, the weight of the child is primarily getting affected. As the malnutrition progresses, gradually over a period of time, the child's length also starts getting affected, while head circumference still remains unaffected in most cases. That is why they say brain is usually the organ least likely to be involved in malnutrition. So head circumference is something which does not get easily involved in malnutrition. And ultimately, if malnutrition keeps on progressing, then ultimately the head circumference also starts getting affected. So initially it's the weight, then it is the length, and finally it is the head circumference. And that is why in types of intrauterine malnutritions which leads to IUGR, so IUGR is intrauterine growth retardation. It's a type of intrauterine growth restriction because of malnutrition of the fetus. Now when that starts happening, when the problem of that malnutrition starts happening in very early fetal life, so there is sufficient time for all the three markers to get affected in the fetus. So the weight also starts getting affected in the fetus, the length also starts getting gradually affected in the fetus, and ultimately there is so much of sufficient time in the intrauterine period that the head circumference also starts getting affected. So when the child is delivered in such cases, the IUGR child has weight affected, length affected, and head circumference also affected. Child appears symmetrically small. That is why we call that type of IUGR as a symmetrical IUGR, because there is sufficient time for all the three markers to get affected. So I've told these quite thoroughly in my classes, the difference between symmetrical and asymmetrical IUGR. So that is why symmetrical IUGRs are usually IUGRs which are because of problems starting early in pregnancy. Torch infections can occur early in pregnancy. Chromosomal disorders can develop early in pregnancy. But for problems that develop late in pregnancy, say for example eclampsias, in those cases there is insufficient time for the intrauterine fetal malnutrition. So initially only weight and subsequently length get affected and the child will be delivered. In those cases the child's head does not get affected. So head remains relatively unaffected and therefore appears to be relatively large compared to the body, and that is why we call that type of IUGR as asymmetrical IUGR. Now using the same analogy, after birth also, whenever malnutrition occurs, initially it's the weight which gets affected. So for a wasting to be defined, what is wasting? Wasting is actually the loss of muscle mass. That is suddenly loss of weight more recently, and therefore the best marker should always be not weight for a particular age, but it should be weight for a particular height. Because if we say weight for a particular age, that will also indicate to an acute malnutrition, but weight for a particular height, because height does not get easily affected. So weight for a particular height will be a better marker for acute malnutrition compared to weight for a particular age. So therefore, while weight for age and weight for height both can indicate to wasting, Because weight for age also keeps on getting affected in chronic malnutrition, which is stunting. We will not say that weight for age is the best marker. The best marker for wasting will be weight for height. So therefore, please remember the best marker for wasting is weight for height, while the best marker for stunting is height for age. And as you have correctly mentioned, most of you, the correct answer for this question number 2 is B, because they're asking the best marker for wasting in children. Suppose they ask the best marker for stunting in children, it should be height for age. And normally the definition, this is what is the best marker. Now, what is the definition of wasting? Well, wasting is defined as weight for height which is less than 2 standard deviation from the expected. Similarly, stunting is height for age which is less than 2 standard deviation from the expected. Or you can say 2 Z score from the affected. And the moment the weight for age and height for age becomes less than 3 standard deviation, it becomes severe wasting and stunting. That is why for a severe acute malnutrition, SAM, the best indicator, one of the indicators for severe acute malnutrition is weight for height, which is less than -3 Z score. So till 2 Z score drop, we say it is wasting or stunting, but the moment it becomes less than 3 Z score, it becomes severe. So just for your exams revision, what is SAM, severe acute malnutrition? The criteria, please remember, as I've told you, the criteria for severe acute malnutrition in a child below 6 months and a criteria for severe acute malnutrition in a child between 6 months to 5 years. So now I will give you 2 criteria out of 3 and you have to tell me in the comment section which is that third criteria. So the first criteria for a child who has severe acute malnutrition, suppose I'm talking about child 6 months to 5 years of age, is a bilateral pedal edema. The second is weight for height, as I've just now told you, which is less than -3 Z score. Now tell me which is the third criteria for severe acute malnutrition in a child who is between 6 months to 5 years of age. Please tell in the comment box. The first criteria is bilateral pedal edema. The second criteria is weight for height, which is less than -3 Z score. Please tell me which is the third criteria. And this is a very important topic for your FMG exams. I am pretty sure that you are aware of this. Visible severe wasting is not for 6 months to 5 years. Please note the age that I am telling you. Don't make such errors in your exams. Please note the age. The age that I'm talking about is 6 months to 5 years. What you are saying is for a child less than 6 months of age. Yes, now you are coming up with the correct answer. The third criteria is mid-arm circumference. Mid-arm circumference less than 11.5 centimeters. Yes, now this is the third criteria. So please do not make an error. When I talk about less than 6 months, bilateral pedal edema is the first criteria. Second criteria again is weight for height, which is less than -3 Z score. Now, if I come to the third criteria for severe acute malnutrition below 6 months, what is that criteria? Come on now, tell me, what is that criteria for severe acute malnutrition below 6 months of age? What is that third criteria? For 6 months to 5 years of age, that criteria was mid-arm circumference less than 11.5 centimeters. But for a child who is less than 6 months of age, which is that criteria? Let me see which is that criteria which you tell me. For a child who is less than 6 months, which is that criteria for severe acute malnutrition? Yes, now it comes to visible severe wasting of muscles. Visible severe wasting of muscles. And by definition, visible severe wasting of muscles is when the ribs can be visible. For example, in chest, I've shown you the picture in my classes of a child who has marasmus. So when you can even see the rib bones, that is when you say that the visible severe wasting of muscles has started. Yes, visible severe wasting. So please remember the criteria for severe acute malnutrition in a child below 6 months and a child between 6 months to 5 years of age. Please know these criteria. Let me quickly, just very quickly, some MCQs let me revise with you related to severe acute malnutrition. So first MCQ that I would like to revise with severe acute malnutrition is, which is usually considered to be the most common cause of death, which is usually considered. Now this is again debatable, but I'm just telling you what most of the books say. The most common cause of death in a child of severe acute malnutrition, the most common cause of death in a child of severe acute malnutrition. I told you some complications of severe acute malnutrition. Which is the most common cause of death? I'll give you options: hypoglycemia, hypothermia, infections, and dehydration. Which is the most common cause of death in severe acute malnutrition? I'm giving you options: hypoglycemia, hypothermia, infections, and dehydration. Which is the most common cause of death in a child of severe acute malnutrition out of the 4 options I've told you? Hypoglycemia, hypothermia, infections, and dehydration. Out of the 4. So you are saying, some are saying infections, some are saying dehydration. Usually the most common cause of death is believed to be hypoglycemia. So which is usually believed to be the most common cause. Again, I'm saying it is debatable, but what most books say is that hypoglycemia in severe acute malnutrition is considered the most common cause of death. I'm again saying this is still debatable, but at least this is what most books say. The second thing is, what is the definition of hypoglycemia? Definition of hypoglycemia in severe acute malnutrition. So it is blood sugar which is less than. So what is the definition of hypoglycemia? Blood sugar which is less than. Blood sugar which is less than. What is the most common definition for hypoglycemia in malnourished children? Now I'm not talking about neonatal hypoglycemia. So blood sugar less than. Let me see what your answer is. Blood sugar less than. So again, this is what I wanted to say. 45 is not the correct answer. That is neonatal hypoglycemia. I'm talking about hypoglycemia in severe acute malnutrition. Be very careful about the question. So answer is blood sugar less than 54 milligrams per deciliter. Less than 45 milligrams per deciliter is neonatal hypoglycemia. But when I'm talking to you about hypoglycemia in a malnourished child, it is blood sugar less than 54 milligrams per deciliter. Now, the third question I would like to ask you is about dyselectrolytemia. Dyselectrolytemia. And I would like to ask you this question: out of sodium, potassium, and glucose, which of these 3 is less in malnourished children compared to normal children? Out of sodium, potassium, and glucose, which is less in malnourished children compared to normal children? Which is less in malnourished children compared to normal children? Out of sodium, potassium, glucose. You can also have 2 as answers. You can have 3 as the answers. You can have 1 as the answer. Which is decreased less in children with malnutrition compared to normal children? So glucose is definitely less. What about sodium? Is sodium less or is sodium high? Is sodium less or is sodium high? Yes, potassium is also less. So hypoglycemia, hypoglycemia, but hypernatremia. This is what is present in malnutrition. So glucose and potassium, very good. So glucose is also less, potassium is also less. Sodium is high in malnourished children compared to normal children. That is why when you are treating children with malnutrition, give fluids which have low sodium but high potassium and high glucose. We later have a question on ReSoMal also. So the correct thing is high sodium, low potassium, low glucose. The fourth thing that I would like to mention and I'd like to ask you is that which mineral or which micronutrient is not started in the first week of management in children with malnutrition? Which mineral or which micronutrient, when you are treating a child of malnutrition, is not started in the first week of management? which mineral, which micronutrient is not started in the first week of management? Let me see. Very good. So the correct answer is iron. Iron is never started in the first week of management because it increases the risk of a condition, it increases the risk of infections. And infections are already occurring in children with malnutrition. So it is never wise to give infections management and iron together, because iron will not support the role of antibiotics. Iron will rather antagonize antibiotics by increasing the risk of infections further. So it is better that in the first week of management of malnutrition, first treat infections, and later on start iron from the second week of treatment. And what is the name of the complication I told you, which can occur if you start very high calories in a child with malnutrition very early? What is that complication I told you if you start calories very early? What is the name of that complication that I told you? If you start calories very early, high calories very early in a child of severe acute malnutrition, what is that complication called? What is that complication called? Yes, that complication is called as, very good, refeeding syndrome. Very good. That complication is called as refeeding syndrome. And refeeding syndrome, as I have told you, includes, in my classes I have told, includes hypophosphatemia, includes hypomagnesemia. All of these are parts of refeeding syndrome. Includes hypokalemia, includes thiamine deficiency. So all of these things are known to occur if you actually give very high calories in a child of severe acute malnutrition. Very good. So let us now come to question number 3. So enough discussion about malnutrition, SAM, markers of malnutrition. Let us come to question number 3. A child previously healthy has been suffering from diarrhea and persistent vomiting since the last 3 days. So this is a child who has previously been healthy, and this is a very important thing that I'm mentioning. Previously healthy child now is suffering from diarrhea and persistent vomiting since last 3 days. The child appears irritable, eyes are sunken, and the child's skin pinch is taking time to go back to normal. So when you pinch a fold of skin, it is taking time to go back to normal. The child is thirsty, and when he's given water, he's drinking water very eagerly. So they are asking, what is the best treatment for this child? Should we give IV fluids? Should we give ORS? Should we give ReSoMal? Should we give dextrose? So what is your correct answer? Your correct answer is ORS, and I will also go with ORS. Now, why is ORS the correct answer? First thing I have to tell you is that when you see whether the child has no dehydration, some dehydration, and severe dehydration, there are certain options or certain things that you see in the history. First thing is, if the child is alert, the child's eyes are not sunken, the child does not appear to be thirsty. If you pinch a fold of skin, it is going back to its place almost immediately. That means the child is not dehydrated. He is in no dehydration. However, in our case, the child is irritable. He is not alert. He is irritable. The child is drinking water very eagerly, so he appears to be very thirsty. The child, when a pinch of skin is, when a fold of skin is pinched, then the fold of skin is taking time to go back to its original place. So it's not going back to its original place almost suddenly or immediately. And the eyes also appear to be sunken. So this does not mean that, so this definitely means that the child is not in no dehydration phase. That means now dehydration has already started happening. No dehydration was when the child appears normal, not dehydrated, not thirsty. But our patient is thirsty, drinking water eagerly, eyes are sunken. So this is definitely dehydration. Now to see whether it's some dehydration or severe dehydration, you have to take a call. So in some dehydration, the child will be irritable. But in cases of severe dehydration, the child will be drowsy, unconscious. In some dehydration, the child will be thirsty. He will be drinking water eagerly. In severe dehydration, the child will not be able to drink water or will be very difficult to drink water or difficult to drink water in severe dehydration. But our patient is able to drink water and is drinking water very eagerly. Eyes are sunken in both cases. And similarly, skin pinch is taking time to go back to its original position. So everything points out to the fact that in our patient, the child has some dehydration. The child doesn't have severe dehydration, and obviously no dehydration is out of question. So child has some dehydration. Very good. So most of you have mentioned correctly. Last point is the child is drinking water eagerly. He is thirsty and drinking water eagerly. So that again is a very important clue that this is some dehydration. Now, why it cannot be ReSoMal? What is the thing that has been mentioned in the question which says that ReSoMal cannot be the option for this question? The thing that is important is the child was previously healthy. A ReSoMal is usually the fluid that is important and is given for children who have malnutrition. So there is a question about, please can you tell us about ReSoMal? ReSoMal, we have a subsequent question on ReSoMal, so I will tell you in detail about ReSoMal, don't worry. So the point that I am trying to make is that ReSoMal is only given in malnutrition, severe acute malnutrition children. And our patient first line says the child was healthy. Everything that has been mentioned in the question, please read the question very carefully because every part of the question may have a hidden meaning. So never underestimate the people who are preparing those questions. They are very seasoned people. They are very, very experienced people. So in just one word, he has told you that ReSoMal cannot be an option here because the child was healthy. So therefore, the child has some dehydration. The child is not dehydrated, not severely dehydrated, and the child is not malnourished. Everything therefore points out to the fact that the child has to be given ORS. So for no dehydration, ORS, some dehydration, ORS, but for severe dehydration, IV fluids. IV fluids will not be the answer here because the child is not in severe dehydration, the child is in some dehydration. How do you treat some dehydration in children? So first, maintain the child's daily requirements, daily fluid requirements. So maintain daily fluid requirements. Whatever is daily fluid requirements, that has to be met. Second thing, the child has to be given ORS 75 ml per kg that will be given over a period of 4 hours. 75 ml per kg that will be given over a period of 4 hours, and then for once the hydration has been done, completed. So now to maintain hydration. To maintain hydration, add 10 ml per kg of ORS after each loose stool. This is just a safety criteria to prevent the child from going into dehydration again. So maintain his daily fluid requirements. Give ORS 75 ml per kg over a period of 4 hours, which is basically the primary way of managing the dehydration. And then once the child's dehydration has been corrected, to prevent the child from going into dehydration again, 10 ml per kg of ORS have to be given after each loose stool. Because if loose stools continue, then the child obviously will go into dehydration again. So 10 ml per kg of fluid has to be given after each loose stool. And as I'm seeing from the options, most of you know what is the way by which you manage some dehydration, and obviously severe dehydration is by giving IV fluid. So ORS is the correct answer in our case. Now there has been a question on ReSoMal. So let us now come to the next question. I will tell you in detail about ReSoMal in this question. So this question number 4 says, which of the following is a correct statement related to ReSoMal compared to low osmolality ORS? So currently the ORS that we give for children who are not dehydrated, previously we were using a ORS which was 311 milliosmoles per liter. That was the high osmolality ORS solution. But seeing some of the disadvantages of that, now we have started using a low osmolality ORS solution for healthy children not otherwise malnutrition, who now are having dehydration. And this new osmolality, low osmolality ORS has an osmolality of 245 milliosmoles per liter. However, as I told you, ReSoMal is basically rehydration solution for the malnourished children. So that's basically the full form of ReSoMal, rehydration solution for the malnourished children. So it's basically the type of ORS that we use specifically for malnourished children. As I've told in my classes, when you are dealing with a child of malnutrition, you have to deal with different types of electrolyte problems that the child is having. Sodium is high, potassium is low, plus glucose also in these children is usually low. So ultimately, you cannot use the same ORS that you use for other children in a malnourished child. Obviously, because in ORS, sodium is very high, glucose is not that high, potassium is relatively low. So the same type of ORS, if we give it to a child who is malnourished and dehydrated, then that probably will not work, rather will cause additional complications, problems. So a special type of ORS that we use for malnourished children is a ORS called as ReSoMal, rehydration solution for the malnourished. Now let us see what are the differences between ReSoMal and the ORS, standard ORS that we use now. ReSoMal and the standard ORS that we use now. As I said, the standard ORS that we use now is the low osmolality ORS. So I'm not talking about the high osmolality ORS which you used in the past. Now, the first thing is talking about glucose. So ReSoMal in glucose is ReSoMal has a glucose content of roughly 125 millimoles per liter. Everything that I'm talking about is in millimoles per liter or milliequivalents per liter. So millimoles per liter, 125 in comparison to ORS which had 75 millimoles per liter. So now you can see the reason for giving ReSoMal is that malnourished children have hypoglycemia and therefore you need higher glucose than normal children to be given to malnourished children. So ORS of malnourished children, which is ReSoMal, has higher glucose content compared to the normal WHO ORS. Similarly, when we talk about sodium, sodium in ReSoMal is relatively lower because, as I told you, in malnourished children, you normally have high sodium. So you don't want to give any further sodium in the fluids, and therefore you give a type of ORS that has low sodium, and the sodium that we have in ReSoMal is 45 millimoles per liter in comparison to 75 millimoles per liter that is there in ORS. Now coming to potassium, as I told you, potassium is low in children with malnutrition. So therefore we need a higher potassium in ReSoMal in comparison to relatively low potassium that is present in WHO ORS solution. So you are seeing the differences, the major differences. The major differences are higher glucose in ReSoMal, lower sodium in ReSoMal, and higher potassium in ReSoMal compared to the standard low osmolality WHO ORS solution. Additionally, chloride is around, I think, 65 millimoles per liter in the WHO ORS solution, while it is around 70 millimoles per liter in ReSoMal, and I think citrate is around, I think, 7 millimoles per liter in ReSoMal, while it is around 10 millimoles per liter in ORS. Plus, I think ReSoMal also contains magnesium, zinc, copper. So if we see the final osmolality of ReSoMal is 300 milliosmoles per liter in comparison to the normal WHO ORS, which has an osmolality of 245 milliosmoles per liter. So while the osmolality of ReSoMal is 300, the osmolality of low osmolar WHO ORS solution is 245. So therefore now let us see the major differences. Glucose is higher in ReSoMal. Potassium is higher in ReSoMal. Sodium is lower in ReSoMal. Chloride is higher in ReSoMal. Citrate is lower in ReSoMal. And overall osmolality is higher in ReSoMal. If you ask me personally what is important for your examination point of view from ReSoMal, talk mainly about glucose differences, sodium differences, potassium differences, and the osmolality differences. So let us revise. ReSoMal has higher glucose compared to the normal WHO ORS. Sodium is lower in ReSoMal compared to the normal WHO ORS. Potassium is higher in ReSoMal compared to the normal WHO ORS. And overall osmolality is again higher in ReSoMal compared to the normal WHO ORS. Now let us come to our main question. So in our main question, they asked which of the following is the correct statement related to ReSoMal. Correct statement. So the first thing that they say, correct, potassium is lower. So potassium is lower is actually an incorrect statement. As I told you, potassium in ReSoMal is higher in comparison to the normal WHO ORS. Then they say sodium is lower. Now this appears to be the correct statement because in ReSoMal, sodium, as I told you, is 45 millimoles per liter compared to a higher osmolality of 75 millimoles per liter of sodium in WHO ORS. Glucose is lower is the third option. This again is an incorrect statement. As I just now told you, glucose is higher in ReSoMal in comparison to the normal WHO ORS. Glucose in ReSoMal is 125 compared to 75 in cases of WHO ORS. And finally, they say overall osmolality of ReSoMal is lower. This again is an incorrect statement. As I just now told you, overall osmolality of ReSoMal is 300 millimoles per liter or milliosmoles per liter compared to 245. So they have lower osmolality compared to normal WHO is also the incorrect statement. So the only correct statement is B. So I hope you have all understood the differences between ReSoMal and ORS. Have you all understood the differences? Let me see a thumbs up sign from all of you if you have understood the difference between ReSoMal. It's again a very important topic according to me for your exams, and ReSoMal is the best fluid for management of dehydration in malnourished children. Have you all understood? Let me see a thumbs up sign from all of you or a yes sir sign from all of you, so that I am also pretty confident that you have understood the differences between ReSoMal. Anything that you want me to add, I'll definitely like to add. If you want me to add anything, I'll be happy to add. IV fluid of choice in malnourished children, as I've again told you, this again a previous year FMG question. IV fluid of choice for malnourished children is either ringer lactate mixed in 5% dextrose or N/2 mixed in 5% dextrose. This is the fluid of choice IV. When we say oral, the fluid of choice is ReSoMal in malnourished children, and IV, the fluid of choice is ringer lactate in 5% dextrose or N/2 in 5% dextrose. For normal children who are dehydrated, the oral fluid of choice is ORS. And for normal children who are dehydrated, the IV fluid of choice is ringer lactate first. If ringer lactate is not there, then the next choice is normal saline. So these are the fluids for dehydration management. Dehydration management fluids of choice for malnourished children, normal children. Let us revise once again. Oral fluid of choice, malnourished children, ReSoMal. IV fluid of choice, malnourished children, is ringer lactate in 5% dextrose or N/2 in 5% dextrose. For a child who is normal, normal means not malnourished but dehydrated, the oral fluid of choice is ORS, right? And for IV fluids, the IV fluid of choice in a child who is not normal. Normal means not malnourished. Normal means not malnourished. So they are dehydrated, but they are not malnourished. The fluid of choice is IV fluid of choice for non-malnourished children is ringer lactate or normal saline. Very good. So I think most of you have understood this. Let us move on to the next question. Question number 5. Question number 5 says the CFTR gene that is mutated in children with cystic fibrosis. So what is the full form of CFTR? The full form of CFTR is cystic fibrosis transmembrane regulatory protein. The cystic fibrosis transmembrane regulatory protein gene is located on chromosome 7. More than 1,500 mutations of this gene can lead to defect in the CFTR protein. And the disease associated with that defect is called as cystic fibrosis. So first thing about your exams, which is important, cystic fibrosis is an autosomal recessive disorder. Second thing about your exam for cystic fibrosis, the CFTR gene is located on chromosome 7. Third thing that is important for your exams about cystic fibrosis is that the defect in cystic fibrosis gene, more than 1,500 mutations cause that defect. And the fourth thing that is important for your exams is out of that defect, the most common mutation that causes CFTR gene to become defective is delta F508 mutation. Or you also call it as DEL F508 mutation. You can call any one of them. This is the most common mutation that causes cystic fibrosis. Deletion of phenylalanine from position 508 on chromosome 7. This is the most common mutation that causes cystic fibrosis. The last thing that is most important question is, which are the two primary electrolytes which cystic fibrosis genes or CFTR protein controls? As you have correctly pointed out, it is sodium and chloride transport. And if I ask you out of sodium and chloride, they asked 2 years back this question, or 1 year back they I think asked this question. Out of sodium and chloride, if they ask you, so they have sodium option also, chloride option also. And out of sodium and chloride, if they ask, CFTR gene and CFTR protein primarily controls the transport of which of these? Sodium or chloride? Which will be the best answer? Out of sodium and chloride. Ideally, it controls both sodium and chloride movement. But if they ask out of sodium and chloride, which is the best answer? So it is sodium or chloride? You should be prepared for that also, because they have already asked that. And as you have correctly mentioned, in that case, it will be chloride. So primarily, it controls the movement of chloride, but can also control the movement of sodium as well. So primarily what it is doing, CFTR protein, it is causing chloride to be secreted into the lumen of the ducts, and it is preventing sodium from getting absorbed from the ducts. This is the primary function of the CFTR protein. It's causing chloride to be secreted into the ducts, and it is preventing sodium from getting absorbed from the ducts. So as a result, sodium and chloride are building up inside the ducts. But when the CFTR gene is mutated and the protein becomes defective, so what will happen? The opposite will happen. Sodium and chloride will start building up outside the ducts. And when sodium and chloride will start building up outside the ducts, obviously the osmolality will increase outside the ducts. And that is why water starts moving from inside the ducts to outside, leading to dehydrated ducts. That's the primary problem of cystic fibrosis. Obstructed, dry secretions inside the ducts. Airways blocked. Pancreatic ducts blocked. Bile ducts blocked. So, primary problem in cystic fibrosis is dry secretions blocking the ducts because they are devoid of water. And why they are devoid of water? Because the water has moved from inside the ducts to outside. And why has water moved from inside to outside? Because sodium chloride has started building up outside the ducts, not inside the ducts. So for cystic fibrosis, let us quickly just revise again some of the important things that I told for your exams. First thing I told about cystic fibrosis is the CFTR gene, which controls the movement of chloride and sodium, is primarily located on chromosome 7. Second thing I told you is more than 1,500 mutations of the CFTR gene are known to cause the defect in the CFTR protein, cystic fibrosis transmembrane regulatory protein. The third thing I told you, the most common mutation of cystic fibrosis is delta F508 mutation, also sometimes called as DEL F508 mutation. The fourth thing I told you, it's an autosomal recessive disorder. And the fifth thing I told you, it's an autosomal recessive disorder. And the fifth thing that I told you, that it controls the movement of sodium and chloride, the transport of sodium and chloride across the hollow ducts, out of which the most important is chloride transport across the ducts. And that is why it becomes a multisystemic disorder. Anywhere where there are ducts, hollow ducts in the body, airways, pancreatic ducts, bile ducts, sweat ducts, excretory ducts, intestines, wherever there are hollow structures in the body, there are dryness of the secretions blocking inside the ducts. And we have another question related to that, and that question related to that will be discussed a little later. All of you are very familiar now with these 5 points. Please be very, very familiar with these 5 points. Cystic fibrosis again is a very, very high importance topic for your FMG exams. Almost every time you have an FMG exam, you are likely to have a question on cystic fibrosis. So I hope you are all familiar with points related to cystic fibrosis. You are all comfortable with the topic of cystic fibrosis? All comfortable with the topic of cystic fibrosis? Please be it's a A+ topic for your exam, cystic fibrosis. Almost every exam of FMG, you might have alternate exams of FMG in which are to ask question on cystic fibrosis. And these are the 5 important things to remember. Chromosome 7, more than 1,500 mutations, most common mutation, autosomal recessive disorder, primarily controls sodium and chloride transport. Let us now come to question number 6. Now question number 6 says a newborn has recurrent bilious vomiting. So this again now is related to cystic fibrosis. Let us come to another point of cystic fibrosis. A newborn has recurrent bilious vomitings starting from day 2 and is sent for a surgical opinion. So there is a newborn, and on day 2 after the child's birth, the newborn starts having bilious vomitings. So bile is coming out in vomiting. The pediatric surgeon suggests a diagnosis of Meconium ileus. So the pediatric surgeon must have done some tests, and after those tests, he suggests that the child may have a diagnosis of Meconium ileus. Now they are asking the newborn's family history is likely to be, remember I said autosomal recessive disorder. So there is likely to be a family history running for cystic fibrosis. So what's the answer here? The answer is cystic fibrosis. This is a very important topic again, Meconium ileus. Meconium ileus cannot be detached from cystic fibrosis. Whenever you have Meconium ileus, there is always discussion about cystic fibrosis. According to one of the books that I have read in pediatrics, almost 80 to 90% infants with Meconium ileus are likely to have cystic fibrosis. This is how common cystic fibrosis is. Almost 80 to 90% infants with Meconium ileus are likely to have cystic fibrosis. And again, the problem is the same. What is happening in cystic fibrosis? The problem is that there is dryness of the secretions. So Meconium, which is almost 80% to 90% water. You all know what is Meconium. Meconium is the first stool of the newborn, and it is almost 80 to 90% water. When all that water dries off, so that hard Meconium starts blocking the terminal ileum, distal ileum. And that hard Meconium blocking the distal ileum. So what will happen therefore? The child first will not pass Meconium after birth. Second thing which is important is that the child will have bilious vomitings. Third thing what will happen is abdomen will start distending. So any newborn baby who starts having bilious vomitings, abdominal distension, not passing meconium after birth, think of meconium ileus as one of the possible differential diagnosis. See, non-passage of meconium is very common. Not passing meconium is very common. It's not very rare, it's common after birth. And there can be a host of criterias. Many times one of the most important reason why a child is not passing meconium after birth is simple dehydration. The child is not getting enough amount of milk, and that is the reason why the child is not passing meconium after birth. So as I've told again in my classes, 24 hours is usually the time when meconium should pass. But even if by 48 hours meconium is not passed, then it becomes a problem. And one of the important reasons why newborn does not pass meconium is they are dehydrated. Then any maternal drug, for example magnesium sulfate, any maternal drug which has been given during pregnancy can pass into the fetus, and after birth these babies also will not pass meconium. So a history of maternal drugs during pregnancy is also very important. Then there are a host of other causes for child not passing meconium. So small intestinal causes and large intestinal causes. And in the small intestinal causes, one of the important causes I have just now told you is meconium ileus. So here what happens is the child basically has a diagnosis of cystic fibrosis, and because of the dryness of the secretions, and in this case dryness of the meconium, those plugs of meconium start blocking the terminal ileum, leading to small intestinal obstruction. So it's basically a type of intestinal obstruction. Right? So meconium ileus is one of the small intestinal problems due to which the child does not pass meconium after birth. Apart from this, duodenal obstructions, jejunal obstructions, they can also be causes of child not passing meconium after birth. Obviously, they have surgical underlying causes. Duodenal obstructions are there, jejunal obstruction, double bubble sign, triple bubble sign. Now, large intestinal obstructions are again important causes of child not passing meconium after birth, and one of the most important cause that comes to our mind in such cases is Hirschsprung disease, which is congenital aganglionosis. So part of the colon or a part of the large intestine is aganglionic. Then in infants of diabetic mothers also, I have told you, small left colon is a condition in which the child does not pass meconium after birth, which is basically more of a type of functional intestinal obstruction, but nevertheless a type of cause of child not passing meconium after birth. You must have heard about causes which are anorectal causes. So anorectal disorders which can be part of some syndromes also. For example, Vectel syndrome. So causes of syndromes, a part of syndromes, anorectal disorders can also be cause of child not passing meconium after birth. So there are a host of causes, list of causes of child not passing meconium after birth. One of those causes is cystic fibrosis, and cystic fibrosis, as I told you, is linked to meconium ileus. It is more or less treated as a type of intestinal obstruction. So it's basically the surgeons who take care of these babies. So going in for X-ray abdomen. In most cases, you are able to diagnose this condition antenatally, that is before the child's birth. So an ultrasound of the mother to look at the baby, how the baby is growing, the fetus is growing. In those cases also you can see dilated intestine loops and hyperechoic masses of the meconium which is stuck inside the intestine. So that can be indicative of the child having meconium ileus. After birth, obviously X-ray abdomen have to be taken both in the supine position and in the erect position, and then contrast enema is also there. So they all can help you in finding out the causes. After birth, usually in many cases enemas can help, therapeutic enemas can help in treatment of meconium ileus. Overall meconium ileus is a condition which, if not properly addressed, can lead to high mortality rates also. So this is something that you should remember. One of the earliest manifestations of cystic fibrosis in newborn, also considered to be the most common manifestation of cystic fibrosis in newborns. Earliest manifestation of cystic fibrosis in newborns, or even if they say earliest manifestation of cystic fibrosis, it should be Meconium ileus because it's occurring in newborns. So it's obviously one of the earliest manifestations of cystic fibrosis. So they ask you which is the earliest manifestation of cystic fibrosis, it's probably Meconium ileus. Which is the most common manifestation of cystic fibrosis in newborns? It's Meconium ileus. So both of these things are very important. And then about Meconium ileus, always linked to cystic fibrosis. As I said, 80 to 90% infants of Meconium ileus have cystic fibrosis. I think I've discussed in quite detail about Meconium ileus. So whenever the word Meconium ileus comes, cystic fibrosis is, and these infants obviously once they have been diagnosed with Meconium ileus, they have to undergo different type of test, and one of the most important test is the sweat chloride test. पूछना है कोई? कर लो start. Okay. So now let us come to question number 7. Let us come to question number 7. So question number 7 says, which of these is the drug of choice for treating recurrent episodes of apnea of prematurity? So again, in my classes, I've discussed about apnea of prematurity. First, I've talked about apneas in newborns. What is the definition of apneas in newborns? So I've told you that 20-second cutoff time is important. So when you're discussing about apnea in newborns, an important topic that you need to know is the definition of apnea in newborns. And for definition of apnea in newborns, the 20-second cutoff time is very important. So what is the 20-second cutoff time for apnea in newborns? So apnea definition says that any newborn who has a temporary cessation of breathing, temporary stoppage of breathing, either for more than 20 seconds, then you call it as apnea, or for the less than 20 seconds, along with changes in the color or the heart rate of the baby. So changes in the color may become pale, the color may become blue. So either the newborn is having paleness or the newborn is having bluishness, or changes in the heart rate, and the most common change in the heart rate noted in apnea is bradycardia. Heart rate starts falling. So any newborn who has temporary cessation of breathing for more than 20 seconds or has temporary cessation of breathing, stoppage of breathing for less than 20 seconds, but associated with either changes in the heart rate or changes in the color, then we will say this is apnea. So this is the definition of neonatal apnea. And neonatal apnea can occur because of a wide range of causes. Respiratory causes of apneas are there. Congenital heart disorders such as PDA, patent ductus arteriosus, they can present with apneas. Then there are apneas which can occur because of CNS causes also. When apnea occurs primarily because of prematurity, that means it does not have an underlying pathological cause, but is primarily occurring because of the prematurity of the respiratory centers in the brain, then this apnea is called as apnea of prematurity. And apnea of prematurity by definition usually does not occur on the first day of life. And similarly, apnea of prematurity is very, very rare, unlikely to happen after 7th day of life. So most of these apneas of prematurities will occur usually in the first week, because after 7th day, usually what happens is the baby's brain gradually starts maturing. So it's in the first 7 days the baby's brain after birth is maturing. So it's unlikely that if apnea is because of a prematurity of the respiratory centers of the brain, that prematurity keeps on persisting even after the first week. So it's unlikely that apnea starts after day 7. And if apnea start after day 7, it's not an apnea of prematurity. Then there is a cause, which is a underlying pathological cause. So classically, this apnea will not occur on the first day. And classically, this apnea will not occur after day 7. So most of these apneas of prematurity, which is relatively a harmless condition, not a very dangerous condition, it's relatively a harmless condition, apnea of prematurity, because it will improve on its own. So unlikely that you need to treat apneas of prematurity. Okay, the staff is checking this. Please just wait for a minute. Okay. So we have tried to correct it from here. So staff is there only helping you out. So I hope now the video will be much better. In case you still have a query or still have a problem, please do write in the chat box. Anyway, so I was talking about apnea of prematurity. So as I said, apnea of prematurity is unlikely to be a cause of major concern. It's only primarily because of the child being premature at birth. So it's not an apnea which is primarily a CNS caused apnea or a respiratory caused apnea. And therefore, apneas of prematurity which are occurring here and there in the first week of life do not require any treatment. According to some of the guidelines, if apnea of prematurities are recurrent in nature, and they require a stimulation, tactile stimulation for the baby to start breathing again, then that requires treatment. So apnea of prematurity is basically considered to be treatable when more than 3 episodes of apnea occur within 24 hours. This is again according to one of the guidelines. So more than 3 episodes, 3 or more than 3 episodes of apnea occur within 24 hours, which requires the child to be given tactile stimulation to restart the breathing process. And what is the drug of choice? As you have all mentioned correctly, the drug of choice is usually caffeine citrate. So caffeine citrate, caffeine citrate is usually considered to be the drug of choice. It's basically a methyl xanthine. And the best thing that is good about caffeine citrate is that caffeine citrate usually does not contain any caffeine citrate usually has a longer half-life and usually has a less of what should I say, less of more a broader therapeutic window and lesser side effects compared to some of its counterparts. Aminophylline, for example, theophylline can also be used. So ideally, the best option A should have been theophylline. So suppose I give you the option A as theophylline. So theophylline can also be one of the options that can be used, but theophylline will not be used here. Theophylline will not be used here because theophylline has a narrow therapeutic window and therefore is likely to cause a greater incidence of side effects, especially because we are dealing with a newborn baby in comparison to caffeine citrate. So if you're given options theophylline, you're given options like doxyphylline, acebrophylline and caffeine citrate, the best answer will be caffeine citrate, right? So there will not be any harm if you give A and there will not be any harm if you give C. So A was also caffeine citrate previously, C was also caffeine citrate previously. So anyway, your best answer is caffeine citrate. So no harm if you answer it as A or C, previous A or C, not now A and C. Previous A and previous C. Now A, theophylline is definitely a wrong answer and should not be considered as the drug of choice. Having said that, let us quickly just see some important questions related to prematurity, which are important from your examination point of view. So first thing that I would like to ask you about is the cutoff time for apnea of prematurity. I've just now told you how many seconds is the cutoff time. Apnea of prematurity, or let us say apnea in newborns. Apnea in newborns. So what is that cutoff time I've told you? Is it 5 seconds? Is it 10 seconds? Is it 15 seconds? Is it 20 seconds? Temporary cessation of breathing for less than or more than 5 seconds, 10 seconds, 15 seconds, 20 seconds. So what is that cutoff time? I've just now told you that cutoff time is 20 seconds. Second, apnea in newborns is more commonly associated with bradycardia or tachycardia. So again, you have to tell me apnea is more commonly newborns associated with bradycardia or tachycardia. Falling heart rate or rising heart rate? Let me see what your answer is. Let me see what your answer is. So apnea in newborns is more commonly associated with bradycardia or tachycardia. Yes, it is more commonly associated with bradycardia. Very good. The next thing that I want to ask is, most common ischemic brain injury in preterm babies. Most common ischemic brain injury in preterm babies. Very important question for your FMG exam. What is that most common ischemic brain injury in preterm babies? Most common ischemic brain injury in preterm babies. What is the name of that injury? I've told you in my classes. What is the most common ischemic brain injury in preterm babies? What is the most common ischemic brain injury that occurs in preterm babies? Very good. The most common ischemic brain injury that occurs in preterm babies is periventricular leukomalacia. Very good. Leukomalacia. Periventricular leukomalacia is the most common ischemic brain injury that you see in preterm babies. Another question, which is the most common site of intracranial bleeding? Most common site of intracranial bleeding in preterm babies. So which is the most common site of intracranial bleed in preterm babies? Most common site of intracranial bleed in preterm babies, which is the most common site of bleeding in the intracranial portion of the newborn, preterm newborns. Very good. So answer is germinal matrix. Very good. So it is germinal matrix. Very good. So it is germinal matrix. Germinal matrix. Which is the most common intestinal injury of preterm babies? Most common intestinal injury of preterm babies. Most common intestinal injury disorder of preterm babies. What is the name of that disorder? Most common intestinal disorder of preterm babies. Remember ABC, ANC, ABC, ANC. What is the name of that disorder? Most common intestinal injury or intestinal disorder of preterm babies. Intestinal, yes, necrotizing enterocolitis. Very good. Necrotizing enterocolitis. Very good. Necrotizing enterocolitis. What is the pathognomonic X-ray sign? Pathognomonic X-ray sign of NEC. Pathognomonic X-ray sign of NEC. Pathognomonic X-ray sign of NEC. What was the name of that pathognomonic X-ray sign of NEC? Let me see if you remember. Pathognomonic X-ray sign of NEC. What was the pathognomonic X-ray sign of NEC? Gas in the bowel. What's the name of that? No, it's not the multiple bubble sign. What's the name of that gas? Yes, pneumatosis intestinalis. Very good. Pneumatosis intestinalis. Pneumatosis intestinalis. Very good. Pneumatosis intestinalis. ABC, ANC. But that was not my question. My question is, what is the name of that disorder? Pneumatosis intestinalis. Okay. Preterm baby, 31 weeks. Preterm baby, let us say 30 weeks. Preterm baby is 30 weeks. Mode of feeding. Mode of feeding. Preterm baby is 30 weeks. Mode of feeding. Let me see what's the mode of feeding. Preterm baby, 30 weeks. What is the mode of feeding? It will be spoon feeds. Will it be Palidae feeds? Will it be tube feeds, or will it be IV fluids? Palidae is not for 30 weeks. Tube feeds, Palidae feeds, spoon feeds, IV fluids. 30 weeks. The age of the baby is 30 weeks. Remember, 34 weeks plus breastfeeds. 32 to 34 weeks, spoon and Pelliday feeds. 28 to 31 weeks is tube feeds. So tube feeds for 28 to 31 weeks. Pelliday is not here. Here it should be tube feeds. 28 to 31 weeks is tube feeds. And IV fluids is for baby who is less than 28 weeks. Yes. What is the definition of hypoglycemia in newborns? And what is the definition of hypocalcemia in newborns? So definition of hypoglycemia in newborns, definition of hypocalcemia in newborns. Let me see whether you are able to tell me. Definition of hypoglycemia in newborns, less than 45, very good. And definition of hypocalcemia in newborns, definition of hypocalcemia in newborns. Definition of hypoglycemia in newborns is 45, less than 45. Definition of less than 7 in preterms and less than 8 in terms. Milligrams per deciliter. So in preterms less than 7, in terms less than 8. Very good. Less than 7 in preterms, less than 8 in terms. Very good. Very good. So most of you are familiar with these topics, and these are again important topics, one-liners, important statements that are important from your FMG examination point of view. And as I see, most of you are well prepared from this topic. Coming now to the next question. Which of the following class of drugs is used as the first line? Please see, controller drug. Don't get confused. I am not asking rescue therapy. So there are two therapies for asthma in children. One is the rescue therapy, which is for treating the acute symptoms. The other is the controller or maintenance therapy. Controller therapy or maintenance therapy of asthma. So I am asking which is the first line controller therapy for asthma. I am not asking first line rescue therapy for asthma. Which is the first line controller therapy, maintenance therapy for asthma. And as you are correctly saying, most of you are correctly saying, the best answer is D, inhaled corticosteroids. So according to the guidelines, whenever a child is brought to you with asthma, the best line rescue therapy is SABA, short acting beta agonist, which ideally should be given, may not be given, but ideally should be given with low dose inhaled corticosteroids, But definitely short acting beta agonist is the first line rescue therapy for asthma. So short acting beta agonists such as salbutamol, terbutaline, these are the rescue therapy for asthma. That is the therapy that is used for controlling acute episodes of asthma. But when there are exacerbations, we have exacerbations of asthma happening again and again, then controllers are given. Controllers are given daily. But controllers, the main purpose is to reduce down the exacerbation episodes of asthma. And the first line exacerbation episode drug is low dose inhaled corticosteroids. So that is why inhaled corticosteroids are the first line controller therapies for asthma. That means in these children, daily inhaled corticosteroids have to be given, and you have to then subsequently assess whether the child is improving or not. That is, daily episodes of asthma or very frequent acute episodes of asthma are improving or not. In case they are not improving, then you see what the child's age is. So if the child is less than 5 years, you have two options available. Either you double the low dose of inhaled corticosteroid, so split it and double the dose. Second thing that you might do is, to a low dose inhaled corticosteroid, you add a second drug to improve the control of asthma. And that second drug in less than 5-year children is leukotriene receptor antagonist, LTRAs, such as montelukast. So they are oral drugs. Now, as a student has correctly pointed out, LABA is not for young children. LABA can be given in older children, but not in young children. In a child more than 5 years of age, in case the controller therapy, low dose inhaled corticosteroid, is not sufficient to control the symptoms, the recurrent symptoms of asthma, then either increase the dose of inhaled corticosteroid from low dose to medium dose, Or a second option would be to add a second drug, and now this second drug in an older child will be LABA, long-acting beta agonist. But LABA not to be given as monotherapy in children. It should always be given in combination with inhaled corticosteroids, and long-acting beta agonists should usually be only restricted to children above the age of 4 to 5 years. It's not for young children. That is very important. So I'm just repeating this again for your benefit, the algorithm. So whenever a child comes with asthma, a rescue therapy is required for acute symptoms and a controller therapy is required if the symptoms are occurring again and again. The rescue therapy is SOS, and the rescue therapy is usually short-acting beta agonist, SABA, inhaled SABA. So this is always usually inhaled SABA. And in case the child is not responding to inhaled SABA, then obviously controllers are required. Now in rescue therapy, now low-dose inhaled corticosteroid is also advised to be combined with SABA for controlling acute symptoms. So according to me, the drug of choice for rescue therapy remains as SABA. So suppose this question would have been drug of choice for rescue therapy of asthma, then the answer would have been SABA, short-acting beta agonist. But here the question is controller therapy. Now controller therapy, the main aim is to reduce down the exacerbation, acute episodes of asthma. First line controller therapy is low dose inhaled corticosteroids, and then in the case the child is not responding, you have to escalate the therapy. Now how to escalate the therapy? There are two ways. In a young child less than 5 years of age, one of the ways to escalate the therapy is to increase ICS dosing. So you are giving once ICS dosing, you might give double the dose of ICS, that low dose of ICS. So that is one way of escalating the therapy. If you do not want to double the low dose, because obviously you're dealing with a corticosteroid, then another option that is there is to add a leukotriene receptor antagonist to ICS in a young child. LABA, as I said, not to be given in young children. In an older child who is more than 5 years of age, in case you want to escalate the therapy because low dose ICS is not bringing the desired results, that escalation can be done either by increasing from low dose to medium dose ICS, inhaled corticosteroids. And the second way to escalate the therapy is to add a second drug. Now in a young child, we were adding LTRA, leukotriene receptor antagonist, because LABAs are not recommended in young children. But in an older child, you might suggest LABA to be added to an ICS, low dose inhaled to inhaled corticosteroids. Long-acting beta agonists can be added, like you are adding salmeterol and fluticasone. So now you're giving salmeterol, fluticasone combination. Fluticasone inhaled corticosteroid, salmeterol is a long-acting beta agonist. You're giving the combination. Right? So that is how you escalate the therapy in case the child is not responding to low-dose inhaled corticosteroids. Biological agents, I don't know, Yasir is asking, sir, is biology agents superior to Leucast? I'm not sure what biological agents. See, the biologic therapies are usually avoided in young children. You know, the biologics, they are associated with too many problems. So although we have for uncontrolled asthma, we have drugs like dupilumab, mepolizumab, then omalizumab. We have those drugs reserved for older children. First, they are reserved for older children. Second, they are drugs which are not given as first-line therapies. They are drugs which are reserved for asthmas that are not getting controlled. So drugs like IL-4 antagonist, IL-5 antagonist, drugs like mepolizumab, drugs like dupilumab, drugs like omalizumab, which is anti-IgE, they all can be given in children, but only as a last choice drug for controlling uncontrolled asthma. First line drugs, definitely it is not recommended. So you have understood the basic therapy in which the basic approach in which we move on to asthma management. This is the asthma approach that you should follow for your exams also. And I hope there should be no confusion in this. You have understood this basic approach? You have understood this basic approach? Okay, very good. Just remember this basic approach. Rescue and controller. Rescue always SABA, and with SABA you can add inhaled corticosteroids. Controller always ICS, low dose. Then escalate the therapy in case not responding. How to escalate the therapy? Either increase the dose of ICS or add a second drug to ICS. Which is the second drug to be added to ICS for a child less than 5 years of age? Preferably add LTRA, leukotriene receptor antagonist. For an older child, preferably add LABA, long-acting beta agonists. And as I said, those drugs like dupilumab, the monoclonal antibodies, dupilumab, mepolizumab, they can also always be added at a later stage when the drugs, first-line drugs are not bringing on the desired results. Now, a preterm child with fast breathing and poor weight gain is brought for evaluation. A preterm child with fast breathing and poor weight gain is brought for evaluation. After examination and investigation, a diagnosis of patent ductus arteriosus is made. Now, there are two ways of treating a patent ductus arteriosus. Either you can do medical management or you can do a surgical management. So either you can do a medical management or you do a surgical management. Now, there are three ways of doing medical management. As I've told in my classes also, prostaglandins are very important for keeping the ductus arteriosus open. So the primary prostaglandin which is known to keep the ductus arteriosus open in the fetal life is prostaglandin E2, which is being released by the lungs. Also, the fetal lung is a source of prostaglandin E2, and a major source of prostaglandin E2 is the placenta. So prostaglandin E2 keep the ductus arteriosus open. So after birth, either the ductus arteriosus closes because of high oxygen exposure, because intrauterine oxygen exposure and extrauterine oxygen exposure, world of difference. So after the child's birth, as the oxygen exposure increases, that is one of the ways to gradually close the ductus arteriosus, or you give a prostaglandin inhibitor. So prostaglandin inhibitors can be helpful in closing the ductus arteriosus, and non-steroidal anti-inflammatory drugs, NSAIDs, are prostaglandin inhibitors. The drugs that have been approved for prostaglandin inhibition are indomethacin, which was the first drug approved for prostaglandin inhibition. The second drug which has been approved for prostaglandin inhibition is ibuprofen. So these are the two approved drugs. They are the approved drugs. But the third drug, which is still not approved, but nevertheless is a drug that has been used for closing the ductus arteriosus, is paracetamol. So indomethacin, ibuprofen and paracetamol have been used for closing the ductus arteriosus. Celecoxib right now has not been used. So the question says, all the following drugs can be used in medical closure of ductus arteriosus after birth, except, so which is the drug that has not been used for medical closure of the ductus arteriosus? It is celecoxib. The approved drugs are indomethacin and ibuprofen, and the unapproved drug, still not approved yet, has been used for medical closure of the ductus arteriosus, paracetamol. Indomethacin and ibuprofen has almost similar efficacy in closing. So this is again one of the questions that students often ask me in the classes. So are indomethacin and ibuprofen, which is better drug out of indomethacin and ibuprofen? See, it's very difficult to choose one between indomethacin and ibuprofen. Indomethacin is time tested, was the first drug approved. Indomethacin and ibuprofen have almost similar efficacy in closing the ductus arteriosus after birth, similar efficacy. The only way where the two differ is the tolerability profile, the side effect profile. Indomethacin relatively is, I would say, a little more harmful drug, if I can say, particularly because it is known to reduce the systemic perfusion. So reducing systemic perfusion, say for example to the kidneys, may lead to problems of kidney inefficiency. So acute kidney injury can occur after giving indomethacin. So very important that you check the input-output of urine when the child is on indomethacin. Plus, reducing down the systemic perfusion to organs such as intestines can also increase the risk of disorders such as necrotizing enterocolitis. So these are complications which have been associated with indomethacin. Ibuprofen has its own share of complications, but definitely I would say a little safer drug in comparison to indomethacin. So if I have to choose between indomethacin and ibuprofen, I would say slightly safer drug in terms of tolerability is ibuprofen. Otherwise, efficacy wise, both indomethacin and ibuprofen are similar. And the third drug which has been used, though yet not approved, is paracetamol. Coming to question number 10, a pretty simple question, I think, and that question is, mid-arm circumference below what value indicates a diagnosis of severe malnutrition? So I've told in my classes that mid-arm circumference on a Shakid's tape, if it is less than 11.5 centimeter, the child will be considered to have severe malnutrition. Between 11.5 to 12.5 centimeters, the child will be considered to have moderate malnutrition. If the child has a mid-arm circumference of more than 12.5 centimeters, the child has no malnutrition. And if the child has a mid-arm circumference of more than 13.5 centimeters, then the child will be considered as normal. Now, the only difference here is that they have mentioned in millimeters. So don't get confused. 11.5 centimeters is 115 millimeters. And since they are asking about severe malnutrition, therefore the best answer is A, and all of you have answered as A. So A is the correct answer. So severe malnutrition less than 11.5 centimeters or less than 115 millimeters. Moderate malnutrition is 11.5 to 12.5 centimeters or 115 to 125 millimeters. No malnutrition is more than 12.5 centimeters or more than 125 millimeters, and normal is more than 13.5 centimeters or more than 135 millimeters. Very good. Coming now to question number 11. Now question number 11 says a 6-month infant is brought to the primary healthcare center with low-grade fever, nasal block and some cough. So the child is a 6-month-old child and he's brought to the primary health center with low-grade fever, nasal blocks and some cough. The respiratory rate of the child was 48 per minute. There are no chest retractions. The mother had fed the child 2 hours back. So this is also important. The mother had fed the child 2 hours back. Now they are asking, what will be your advice to the mother? So broadly speaking, I'm saying the child is a 6-month infant. The child has some fever, the child has some nasal block, the child has some cough. Now the child has a respiratory rate. Now this is very, very important, and this is based upon what your answer will be. Respiratory rate, chest retraction. And as I'm very proud of you, because I was expecting you people to be a little confused here, because this is a 6-month-old child and is having low-grade fever and cough. But you have all correctly hit the nail by saying that even though the child has fever and cough, because his respiratory rate is 48 per minute, which is a normal respiratory rate for a 6-month-old child. So the child is unlikely to have pneumonia. I told you pneumonias are only likely to occur when there is either fast breathing or chest retractions. But here there is neither fast breathing nor chest retractions. Danger signs are not there. The child is taking feeds. See the last line, the child is taking feeds. So even the danger sign is not there. What was the danger signs I told you? The mnemonic for the danger signs. Very unwell child, persistent vomitings, unconscious or lethargic child, unable to drink anything, having convulsions or having history of convulsions. Nothing is present in this baby. So this baby appears to be a baby who is just having a cough and cold. So what's the diagnosis of this child? The diagnosis of this child is only cough and cold. Pneumonia would have been when there is either fast breathing or when there is chest retraction. What was the criteria for fast breathing? I've told you in my classes. The criteria for fast breathing that I've told you in my classes are child below 2 months. Criteria for fast breathing is more than 60 per minute. 2 to 12 months, criteria for fast breathing is more than 50 per minute. Then between 1 to 5 years, class more than 40 per minute. So if you see our patient is 6 months of age. He lies in this category. The patient who's come in, the patient in our question is 6-month-old child. So this child is having an age of 6 months. So if his respiratory rate would be more than 50 per minute, then I would say he is having fast breathing. But what is the respiratory rate in our patient? Our patient respiratory rate is less than 50 per minute. So the child does not have fast breathing. So first, no fast breathing is there. Second, no chest retractions are there. Third, danger signs. Are we seeing any danger signs which would have helped us classify this child as a severe pneumonia or a very severe disease? So do we have those 4 danger signs? Which are the danger signs I told you? I told you danger signs like persistent vomiting. This child does not have that. Unable to drink anything. This child is drinking. Unconscious lethargic child. The child does not have anything like unconsciousness in this question. And a child who has history of convulsions or is presently convulsing. Again, nothing in our... So in our case, normal respiratory rate, no chest retraction, no danger sign. Therefore, in our case, no antibiotics are required. Which color category? Green color category. No antibiotics required. And therefore, the child's best management will be treat the child at home. No need for giving any antibiotics. This would have been for a child who is in the yellow category. This would have been for a child who is in the pink category. Again, pink category. But not for this. This is for the green category. Our patient is in the green category. Ampicillin, gentamicin, treat fever and cough. Review after 2 days. This is pink category. Suppose I ask you the patient is having diarrhea, vomiting, is irritable, is thirsty. Which category will this be? Green color category, yellow color category, pink color category. Let me see. Diarrhea and vomiting since the last 3-4 days. Child irritable. And the child is drinking water eagerly. Which color category should I put this child in? Green color category, yellow color category, pink color category. Let me see. Diarrhea, vomiting, irritable child. Thirsty, drinking water eagerly. I've got one answer as green. One answer as pink. I expect you know which type of dehydration is this? Diarrhea, vomiting, irritable, thirsty. I've just now told you few questions back. What is this type of dehydration? Is it no dehydration, some dehydration or severe dehydration? Which type of dehydration is this? Diarrhea, vomiting, irritable, thirsty. Which type of dehydration is this? No, some or severe. I just told you a few minutes back. Which type of dehydration is this? This is some dehydration. Yes. So how will you put a some dehydration in a pink category? No, some dehydration is in the yellow category. Some dehydration cannot be in green category also. Green category is no dehydration. Some dehydration is yellow category. Severe dehydration is pink category. Now suppose I change this question. I say child with diarrhea, vomiting, currently lethargic, not drinking water. Now which color category is in? Not drinking water. What color category is this? Now this will become severe dehydration and this category will suddenly change to pink category. So he's asking what about the danger sign? There is no danger sign in our patient. Where is the danger sign? In our patient they have written that child is drinking water well, has taking feeds normally. So there is no danger sign. So this is pink color category. Right? Please be very careful about the symptoms given in the question. They will always be giving you some clues in the question. This is now your effort how to find out the clues and link it to the answer. They will definitely give you the clues in the question. The only thing that you need to do is to remember from your notes, connect the clues to the correct question. तो वॉमिटिंग से क्या हो जाता है? वॉमिटिंग, persistent vomiting is a danger sign. Vomiting अगर मैंने लिखा है, if I just write vomiting, 2 episodes of vomiting, it's not a danger sign. What is a danger sign? Persistent vomiting. Word is persistent. अच्छा हुआ पूछ लिया. Good that a student has asked that sir, vomiting is written. But vomiting, अगर 2 episodes, if there are 2 episodes of vomiting, it does not become a danger sign. I said the danger sign is persistent vomiting. Vomiting again and again and again and again, it's not stopping. Persistent word is important. I've never said vomiting is a danger sign. Persistent vomiting is a danger sign. Right? I hope The person who asked this question has understood. Okay, question number 12. Question number 12 says a child with cyanosis and breathing difficulty on playing is brought for cardiac evaluation. So there is a child who is having breathing difficulty and cyanosis, and this child is brought to you for cardiac evaluation, and echocardiography is done. Now, when the echocardiography is done, it confirms that the child has a heart disease. The X-ray of the child is shown to you. What type of sign is this? What type of sign is this? You're seeing which type of sign? So you are seeing a TAPVR sign. Very good. So this is a sign of figure of 8. This is a sign of figure of 8. Very good that you have been able to, or a snowman heart sign. Very good. So this is figure of 8 or a snowman heart sign. So, okay, let us see some of the questions from congenital heart diseases. Let us revise some of the questions from congenital heart diseases for your FMG exams. So, figure of 3 sign, answer. X-ray shows figure of 3 sign. What is the answer? X-ray shows figure of 3 sign. What is the answer? X-ray shows figure of 3 sign. What is the answer? X-ray shows figure of 3 sign. What is the answer? Very good. The answer is coarctation of aorta. Very good. Answer is coarctation of aorta. Figure of 3 sign, coarctation of aorta. X-ray shows box-shaped heart. X-ray shows box-shaped heart. What is the diagnosis? X-ray shows box-shaped heart. What is the diagnosis? X-ray shows box-shaped heart. What is the diagnosis? Yeah, the X-ray shows box-shaped heart. The diagnosis is Epstein's anomaly. X-ray shows box-shaped heart, Epstein's anomaly. Very good. X-ray shows boot-shaped heart. X-ray shows boot-shaped heart. What is the heart disorder? X-ray shows boot-shaped heart. What is your diagnosis? X-ray shows boot-shaped heart. What is the diagnosis? Very good. The diagnosis is Tetralogy of Fallot. Very good. Diagnosis of Tetralogy of Fallot. X-ray shows egg on string appearance. X-ray shows egg on string appearance. What is your diagnosis? X-ray shows egg on string appearance. What is your diagnosis? X-ray shows egg on string appearance. What is your diagnosis? Yes, your diagnosis is transposition of the great arteries. X-ray shows transposition of the great arteries. Yes, very good. Most common cyanotic congenital heart disease. Most common cyanotic congenital heart disease. Which is the most common cyanotic congenital heart disease? Let me see your answer. Most common cyanotic congenital heart disease in children. Most common cyanotic congenital heart disease in children. I'm not asking most common congenital heart disease in children. That is why I say be very careful about the question. आपको एक exam मिलेगा. You'll just get one exam. You will be back 6 months if you answer in a hurry. I did not say most common congenital heart disease. I said most common cyanotic congenital heart disease. Answer is TOF. Very good. Which is the most common cyanotic congenital heart disease in newborns. Most common cyanotic congenital heart disease in newborns. Which is the most common cyanotic congenital heart disease in newborns. In newborns. Most common cyanotic congenital heart disease in newborns. Most common cyanotic congenital heart disease is TOF, but most common cyanotic congenital heart disease in newborns is TGA. Some are asking and some are answering. TOF as the TGA. So most common cyanotic congenital heart disease is TOF, but most common cyanotic congenital heart disease in newborns is TGA. Which congenital heart disease carries highest risk of infective endocarditis? Which congenital heart disease has the highest risk of infective endocarditis? Congenital heart disease with the highest risk of infective endocarditis. Which congenital heart disease has the highest risk of infective endocarditis? Very good. So VSD has the highest risk of infective endocarditis. Highest risk of infective endocarditis is VSD. Which congenital heart disease has the lowest risk, least risk? Lowest risk of infective endocarditis. Which congenital heart disease has the least risk of infective endocarditis? Least risk of infective endocarditis. Very good. So congenital heart disease with the least risk of infective endocarditis is ASD. Very good. Congenital heart disease with the least risk of infective endocarditis is ASD. Which congenital heart disease carries the lowest risk? Lowest risk of heart failure. Which congenital heart disease has the lowest risk of heart failure? Lowest risk of heart failure. Yes, the congenital heart disease with the lowest risk of heart failure is TOF. Very good. Congenital heart disease with the lowest risk of heart failure is, so lowest risk of infective endocarditis is ASD, lowest risk of heart failure is TOF. Which congenital heart disease with the highest association with right aortic arch? Which heart disease? Which congenital heart disease is most commonly associated with right aortic arch? Which congenital heart disease most commonly associated with right aortic arch? No, not TOF. Highest, which congenital heart disease most commonly? Yes, very good. Truncus arteriosus more than TOF. Both TOF and truncus arteriosus are associated with right aortic arch, but truncus arteriosus is the best answer. Truncus arteriosus has the highest association with, yes, highest association with. So you will remember everything, all these things you will remember. Congenital heart disease related, these one-line questions you will remember for your exams. In my classes, when I was taking the classes, you all promised that you'll go through the notes. At that time, possibly it was difficult to remember everything, but later on, sir, we'll remember everything because you have understood the congenital heart disease as well. Have you all understood congenital heart disease after the second revision? I hope you have all gone through the second revision. Have you all understood the congenital heart diseases at least 50-60% be, if you remember those congenital heart diseases the way I've taught you? The classification of heart diseases, acyanotic, cyanotic heart diseases. Have you all understood those congenital heart diseases? Very good. Most of you say yes. Very good. That is what makes us happy also. Coming now to question number 13. Question number 13 says, a child with seizures during episodes of high fever is being seen in pediatric OPD. A diagnosis of febrile seizures is suspected. So there is a child who is brought with history of seizures occurring in association with high-grade fever. A diagnosis of febrile seizures is made. Now they are asking which of the following is not used as a criteria to differentiate a simple febrile seizure from a complex febrile seizure. So I told you that febrile seizures are divided into simple and complex febrile seizures based upon certain criteria. So let me see which is the criteria which is not used to differentiate a simple febrile seizure from a complex febrile seizure. Yes, most of you are giving a correct answer. Very good. The correct answer is treatment of seizures is not the criteria. So first, generalized seizures and focal seizures. Second, number of seizures. So single seizure per episode of fever and multiple seizures per episode of fever. So this again is the criteria. And the third criteria is duration less than 15 minutes and duration more than 15 minutes. Duration less than 15. So duration is a criteria for differentiating simple from complex febrile seizures. The number of seizures is the criteria for differentiating simple from complex febrile seizures. And type of seizures, generalized or focal, is again a criteria for differentiating simple and complex. Treatment of seizures has to be the same approach. You cannot differentiate based upon the treatment of seizures, whether it's simple or complex. It may be a simple febrile seizure, it may be a complex febrile seizure. The treatment of seizures will be the same in a simple febrile seizure also and a complex febrile seizure also. So therefore, based upon the treatment, you cannot differentiate whether this is a simple febrile seizure or a complex febrile seizure. Right? Okay. Coming now to question number 14. Which of the following congenital heart, and we have already discussed this, so I won't go into the details again. We have already discussed this. Let me see if you are able to answer correctly. Which of the following congenital heart disease is most likely present in a child with cyanosis without cardiomegaly of heart failure? So let me see. It's a little catchy, but I think you should be able to answer. A cyanosis but without heart failure. Which congenital heart disease is this? Cyanosis but without heart failure. Very good, very good. So the answer is STOF. I just now told you which congenital heart disease is associated with the least risk of heart failure. And that congenital heart disease, cyanotic heart disease, STOF. So which heart disease? Very good. So I was again a little apprehensive whether you will be able to answer this correctly or not. A little twisted question. They have given the statement I said. The heart disease with the least risk of heart failure, congenital heart disease with least risk of heart failure is STOF. I've just twisted it slightly in the form of a statement where I've said which of the following congenital heart disease is cyanotic but without cardiomegaly and heart failure, and the answer is Tetralogy of Fallot. Very good. Coming to question number 14. Which of the following cardiac abnormalities are common in Trilogy of Fallot, Tetralogy of Fallot and Pentalogy of Fallot? So I have told you different types of Fallot disorders. So Trilogy of Fallot, I told you what is Trilogy. I told you what is Tetralogy. And I told you what is Pentalogy or Pentad. So Tetralogy of Fallot, I told you, is pulmonary stenosis, right ventricle hypertrophy, VSD and aorta overriding the VSD. Aorta overriding the VSD. Here I told you it is pulmonary stenosis, right ventricle hypertrophy, VSD, aorta overriding the VSD and ASD. So in Pentad of Fallot, ASD is also there. ASD is also there. And in Trilogy of Fallot, you have pulmonary stenosis, you have right ventricle hypertrophy, and you have ASD. So what is common? Yes. So what is common in all the three disorders? It is pulmonary stenosis and right ventricle hypertrophy. Again, very good. It is pulmonary stenosis and right ventricle hypertrophy, which is common in Trilogy of Fallot also, Tetralogy of Fallot also, Pentalogy of Fallot also. So again, you should know what are the components of Trilogy of Fallot, Tetralogy of Fallot, Pentalogy of Fallot. And since you have answered immediately, that means you are all aware about Trilogy, Tetralogy and Pentad, and the thing that is common in all of them will be pulmonary stenosis and right ventricle hypertrophy. Coming to question number 16. Question number 16 says a neonate is brought for pediatric evaluation with a history of icterus starting from day 3 after birth. So there is a newborn who is brought for pediatric evaluation and the child has a history of icterus starting from day 3 after birth. Now they are asking, the pediatrician will consider a diagnosis of physiological jaundice if the icterus persists not longer than, so what will be the correct answer? If the icterus persists for not longer than, let me see what your correct answer is. Yes, physiological jaundice, but I'm getting different answers. Some are saying A, some are saying B, some are saying C. So what was the criteria for physiological jaundice? If you remember in my class, I have told you the criteria for physiological jaundice. Jaundice not appearing on day 1. Second, jaundice not persisting beyond 2 weeks, not persisting beyond 14 days. And total serum bilirubin not more than 15 milligrams per deciliter. So it is less than 15 milligrams per deciliter. If these criteria are there, we say that this is physiological jaundice. So the answer is not day 7, answer is day 14. See, don't get confused. I said most cases physiological jaundice rises from day 2 to day 3, reaches a peak by day 4 to day 5 and comes down by day 7. But even if it persists by day 14, we will call it as physiological. So you cannot say day 7 or day 10 is the cutoff. The cutoff criteria for physiological is day 14. So ideally, in most cases, physiological jaundice of newborns will come down by day 7. But even if a jaundice is persisting beyond 14 days, beyond 7 days, but till 14 days, that will still be considered as physiological jaundice. So the cutoff will be 14 days. The cutoff will not be 14 days, will not be 7 days. What is the best treatment for, most commonly used treatment for neonatal jaundice? Most commonly used treatment for neonatal jaundice. Let me see what your answer is. Most commonly used treatment for neonatal jaundice. What is the most commonly used treatment for neonatal jaundice? Not UV. Don't say UV. Most commonly used treatment for neonatal jaundice. Yes, phototherapy. Phototherapy. What is the most commonly used treatment for neonatal jaundice? Phototherapy. Very good. Then most common mechanism by which phototherapy works. Most common mechanism in phototherapy which is helpful in reducing bilirubin. What is the most common mechanism? Structural isomerization, configurational isomerization and photooxidation. Which is the most common mechanism by which phototherapy works? Structural isomerization, configurational isomerization or photooxidation. Which is the most common mechanism by which phototherapy works? Structural isomerization, configurational isomerization or photooxidation. Which is the most common mechanism? I should not say most common. I'm sorry, my question is a little wrong. Most effective mechanism. Sorry, it should be most effective mechanism in phototherapy. So which is the most effective mechanism phototherapy? Very good, it's structural isomerization. Let me reframe this question. Lumirubin is a byproduct of structural isomerization, configurational isomerization or photooxidation. Lumirubin is a byproduct of structural isomerization, configurational isomerization, photooxidation. Lumirubin is a byproduct of structural isomerization. Very good. Lumirubin is a byproduct of structural isomerization. Lumirubin is a byproduct of structural isomerization. Very good. Structural isomerization. What is the wavelength of light? What is the wavelength of light used in phototherapy? What is the wavelength of light used in phototherapy? Wavelength of light used in phototherapy. So what is the wavelength of light used in phototherapy? What is the wavelength of light which is used in phototherapy? Very good. So it is 460 to 490 nanometers, blue or blue-green light. 460 to 490 nanometers. Very good. 460 to 490 nanometers. Let me see this. Gray baby syndrome is a complication of? Gray baby syndrome is a complication of? Gray baby syndrome. I'm not asking brown baby syndrome. Bronze baby syndrome. I'm asking gray baby syndrome. Let me see. Gray baby syndrome is a complication of Gray baby syndrome is a complication of, let me see what your correct answer. I've told this in my class again. Yes, chloramphenicol. Very good. Chloramphenicol toxicity. So gray baby syndrome is a complication of chloramphenicol toxicity. Gray baby syndrome is a complication of bronze baby syndrome is a complication of phototherapy. Very good. Bronze baby syndrome is a complication of phototherapy. Okay, Gilbert syndrome, Rotor syndrome, and Dubin-Johnson syndrome. Which of these is associated with conjugated jaundice? Gilbert syndrome, Rotor syndrome, Dubin-Johnson syndrome. Which is associated with conjugated jaundice? It can be 2 also. Answer can be 2 also. Answer can be 3 also. Which is associated with conjugated jaundice, not unconjugated. Conjugated jaundice. Gilbert syndrome, Rotor syndrome, Dubin-Johnson syndrome. Which are associated with conjugated jaundice? Doctors are conjugated. So Dubin-Johnson and Rotors are conjugated. Very good. Dubin-Johnson and Rotors are conjugated. Rotor and Dubin-Johnson. Gilbert is unconjugated. Very good. Rotor and Dubin-Johnson are conjugated and Gilbert is unconjugated. Last question that I would like to ask you. Twice this has been asked in NEET PG, I think also. Which of these is a cause of neonatal jaundice appearing in the first 24 hours of life? Please hear this question. Which of these is a complication or a cause of neonatal jaundice appearing within the first 24 hours of life? RH incompatibility between the mother and the baby, then congenital hypothyroidism, and neonatal hepatitis. My question is, which of these causes of neonatal jaundice causes jaundice to appear within 24 hours of life? There are 3 options given. You have to say which is the correct option. Which of these causes jaundice to appear within 24 hours of life? Congenital hypothyroidism, RH incompatibility, and neonatal hepatitis. Don't make options from your own. Yes, RH incompatibility. RH incompatibility is a cause of jaundice appearing within 24 hours of life, or any defect related to the RBC structure. Say for example, G6PD deficiency, hereditary elliptocytosis, hereditary spherocytosis, RH incompatibility. Even torch infections causes jaundice to appear very early. But congenital hypothyroidism, neonatal hepatitis, if you remember, neonatal hepatitis is more commonly a cause of cholestasis. So here usually the jaundice appears late, after the 2nd week of life. Very good. So again, I think you are very well prepared from neonatal jaundice chapter. Question number 17, the most common malignant brain tumor in children, also considered an embryonal malignancy. So there are 2 clues given in this question. Most common malignant brain tumor in children, embryonal tumor in children. They are asking, this tumor is known to arise from which part of the brain? So first you need to know what is that brain tumor, which is the most common malignant brain tumor. And then you also need to know which is that brain tumor which is an embryonal tumor. And then you need to know that this tumor appears from which part of the brain. So yes, that tumor is, what is the name of the tumor? Medulloblastoma. Medulloblastoma. And medulloblastoma is known to arise from the cerebellum. Very good. Let me see if you can tell me, medulloblastomas are known to arise from which part of the cerebellum? Usually they can arise from the periphery also, from the center also. They can arise from the periphery and center also, but more commonly they are known to arise from, medulloblastomas more commonly are known to arise from the center. So midline masses, center compared to the periphery. Center compared to the periphery. Yes, center of the cerebellum. Very good. Which brain tumor is the most common tumor of infants? Which brain tumor is the most common tumor of infants? Most common brain tumor in infants. Let me see if you can tell me the answer. Most common brain tumor of infants. Which is the most common brain tumor of infants? Which is the most common brain tumor of infants? No, not astrocyte. No, not craniopharyngioma. You have forgotten this. Most common brain tumor of infants is choroid plexus tumor. Yes, choroid plexus tumor. Most common brain tumor in infants. Choroid plexus tumors. Very good. Craniopharyngioma. Craniopharyngioma is the most common, is the brain tumor associated with supracellular calcification. That is craniopharyngioma. But which is the most common brain tumor of infants? It is choroid plexus tumor. Right? Very good. Come now to question number 18. An infant with recurrent tonic spasms and head drops episodes is brought to the emergency. So there is a infant. First clue, there is an infant. Second clue, the infant has been brought to you with recurrent tonic spasms and head drop episodes. Head drop episodes. These head drop episodes are sometimes also called as salam seizures. Now, when this child undergoes an EEG, what is the most likely finding in that EEG? Let me see what your answer is. What is the most likely finding in that EEG? Yes, the most likely finding in that EEG is a disorganized rhythm. This is very good, West syndrome or infantile spasms. So this is West syndrome or infantile spasms. And the typical EEG is called as hips arrhythmia. Typical EEG is called as hips arrhythmia. Very good. Yes, hips arrhythmia. So this is a West syndrome. First clue that this is a West syndrome, this is an infant. Second clue, the child is having tonic spasm, head drop episodes. These head drop episodes are also called as salam seizures. So considering that this is an infantile spasm, the child's EEG should show a disorganized rhythm, which is called as hips arrhythmia. And the drug of choice, what is the drug of choice? Yes, drug of choice in these children is ACTH. In case ACTH is not one of the choices, then vigabatrin can be given. But ACTH should be the drug of choice for a child with infantile spasms. 3 Hertz in absence seizures. Very good. A child with short stature is being evaluated. Child with short stature is being evaluated. A diagnosis of constitutional delay is consistent with all of these statements. So now they are saying, in case a child of short stature is evaluated and is found to be a case of constitutional delay, which out of these statements is not consistent with a diagnosis of constitutional delay? So are constitutional delay cases physiological short statures? Yes, they are. Are constitutional delay cases most common type of short statures in children? Yes, they are. Are constitutional delays associated with delayed puberties? Yes, they are. Do constitutional delay children have growth hormone levels mildly reduced? No, they don't. So therefore, the only thing that is not consistent with the diagnosis of constitutional delay is D. Growth hormone is not associated with constitutional delay. Constitutional delay children may have reduced IGF-1 levels. Constitutional delay children may have reduced IGF-1 levels, but growth hormone levels are not associated, and they are definitely not reduced in children with constitutional delay. So constitutional delay is a physiological short stature. Constitutional delay is the most common type of short stature in children. Constitutional delay is a type of short stature with delayed puberties. When you compare it with a familial short stature is again a physiological short stature, but in a familial short stature, there is a history of short parents. One or both parents are short, not history of delayed puberties. And in a familial short stature, it is not the most common type of short stature in children. The most common type of short stature is constitutional delays. So both these are types of physiological short statures in children. Coming to question number 20. Now shown in the picture is a systemic pulmonary shunt. So there is a shunt which is starting from the aorta and the shunt is connecting the pulmonary artery. So you can see the shunt. A little tricky question, but I thought that I'll put this question and see if you are able to tell me the answer. So they are saying this type of shunt can improve symptoms in children with. So see what is happening. There is an aorta, there is a pulmonary artery, and you can see that there is a shunt between the aorta and pulmonary artery. Now after birth, since the pressure is more in the aorta than the pulmonary artery, so this shunt appears to be carrying blood from aorta to the pulmonary artery. That means it appears to be taking the blood from the systemic circulation to the lungs. Now, can you tell me in which type of heart disease is mentioned in the option? This type of shunt will be helpful, where blood is able to grow from the aorta to the pulmonary artery and it will help the child. Please try to understand this question and then answer. So, see, let me give you an example. Suppose this is the heart, the right atria, the right ventricle, the left atria and the left ventricle, and suppose this is the lungs. So in cases such as TOF, in cases such as tricuspid atresia, in cases such as tricuspid atresia, blood to the lungs is actually reduced. If you remember, both TOF and tricuspid atresia come under which classification of cyanotic heart diseases? Cyanotic heart diseases with reduced pulmonary flow. Remember I told you acyanotic heart diseases, cyanotic heart diseases. Cyanotic heart disease with reduced pulmonary flow, cyanotic heart disease with increased pulmonary flow. So TOF and tricuspid atresia are cyanotic heart diseases with reduced pulmonary flow. That means the flow to the lungs has reduced. Now what type of shunt will help in such cases? Till the time a surgery is performed, a shunt which is able to take the blood from systemic circulation to the pulmonary circulation till the time surgery is performed, because here what is happening is the blood flow to the lungs has reduced. In TOF also the blood flow to the lung has reduced. In tricuspid atresia also blood to the lungs has reduced. So therefore in such cases, which type of shunt can help? So this is the pulmonary artery, this is the aorta. So in this case, which type of shunt can help? In this case, a shunt can help if there is passage of blood from the aorta to the pulmonary artery so that the blood can go to the lungs. So what type of shunt is helping here? A aortopulmonary shunt is helping. Aortopulmonary shunt is helping, and therefore this will help any child who has a cyanotic heart disease with reduced pulmonary flow, such as tricuspid atresia, such as Tetralogy of Fallot. And therefore, which is the best answer? In this case, the best answer is Tetralogy of Fallot. That is why we keep the ductus arteriosus open also in such cases by giving prostaglandins. In PDA, you are closing the ductus arteriosus, but in cases like TOF, tricuspid atresia, we keep the ductus arteriosus open so that blood can keep going from the aorta to the pulmonary artery before the palliative procedures or surgeries are performed. In this case, we have created a shunt between the aorta and pulmonary artery to allow the blood to go to the lungs till the time the surgery is performed. So which type of heart diseases this shunt will help? Heart diseases in which the pulmonary blood flow is reduced, such as tricuspid atresia and Tetralogy of Fallot. Have you all understood this? I have told this in my classes also, but I think it was a concept-based question. If I keep on asking all simple questions, then it will become very simple for you. It was a slightly concept-based question. Have you all understood the concept behind the question? Yes, that is also called as the Blalock-Taussig shunt. Very good. Now you remember I have told in my classes, some of my classes also, Blalock dissection. Have you understood the concept behind this question? The concept behind this question is that there is a reduced pulmonary flow in tricuspid arteries and TOF, cyanotic heart disease with reduced pulmonary flow. So when the child will be born, if the pulmonary blood flow is reduced, then what will happen? The lungs will not get blood for oxygenation. So you need to create a shunt between the aorta and pulmonary artery so that the blood till that time can go from the aorta to pulmonary artery. Now this is not a ductus arteriosus. आप देख रहे हो, this has been sutured. यहाँ पर sutures देख रहे हो आप, sutures लगे हुए. So this is a shunt that has been created. And where will the blood flow from aorta to the pulmonary artery or pulmonary artery to the aorta? It will flow from aorta to pulmonary artery because after birth, the pressure is more in the aorta than in the pulmonary artery. So the aim of this shunt is to send the blood into the lungs till the time surgery is performed. Or lungs mein, we will send the blood only when the lungs are getting less blood. So which type of condition it will help? It will help a child who has tetralogy of Fallot. So Yasir is saying, अरे हाँ ये तो बताया था सर ने, but अभी late हो गया. Okay, so this is just a type of जब लोग सोने लग जाते हैं, when the students start going a little sleepy, when there are very simple questions. So this is type of an eye opener कि जाग जाओ. This is a type. This is still a very simple question, not a very difficult question, but जाग जाओ because you need to. And this is a concept based question. This is not a question जिसमें बहुत revision की जरूरत है. It's a concept based question. अगर आप concept आपको clear है, if you are clear with the concept, you will be able to answer this question. Anyway, coming back again to very simple questions. Let me see now if you will be able to answer these simple questions. Question number 21 says a 6-year-old boy is brought by his mother to a pediatrician with history of increasing periorbital edema since the last 3 months. So there is a child who has been brought with a history of increasing edema around the eyes. The child's urine examination shows proteinuria. So protein is passing in urine and urine protein to creatinine ratio is 2.5, which is very, very high protein passing in the urine. So what is this disorder? This disorder is nephrotic syndrome. What is this disorder? The disorder is nephrotic syndrome in children. Now the only thing they want to ask is which of the following is correct for nephrotic syndrome in children. So you tell me now out of A, B, C and D, which is correct for nephrotic syndrome in children? Out of A, B, C and D option, which is correct statement for nephrotic syndrome in children? Most children with nephrotic syndrome, do they have elevation of urea? No. Nephrotic syndrome in children mostly is a minimal change disease. And minimal change disease is not associated with any increase in the urea. Focal segmental glomerulosclerosis is not the most common cause of nephrotic syndrome in children. I am again repeating, nephrotic syndrome in children is mostly minimal change disease. Is cholesterol low in nephrotic syndrome? No, cholesterol is high in nephrotic syndrome. So the only correct answer, as you all have correctly mentioned, is selective proteinuria. That is the most important feature of nephrotic syndrome in children. Selective proteinuria, which means only low molecular weight proteins are lost in urine, not the high molecular weight protein. This again I have mentioned in my classes that one of the most important features of nephrotic syndrome in children is selective proteinuria. I got less answers as D. Most of you have given as D, but I have got less answers. I was getting more answers. Have you found this question again difficult? This is not a difficult question. Again, a little concept-based question. But please start preparing for these type of questions for your exams. Now, FMG exams, as time is passing by, FMG exams are no longer only pass-fail exams. Pass-fail is there, but it's not as simple as single liners. This is the answer, this is the answer, this is the answer, this is the answer, this is true, this is false. No. Now there are little concepts involved in these type of questions, and this is an example of concept-based questions. Please prepare for such concept-based questions for your exams. This again I have mentioned in my class. Let me see if you are able to recollect this. Again I mentioned in my class. Kakut. Okay. CACUT is the commonly used acronym for congenital abnormalities in children pertaining to which organ system? So let me see if you remember what I told you about CACUT. Okay, test city allotments have been done. Okay. CACUT, what is, yes, CACUT. Yes, CACUT I told you is congenital abnormalities of the kidney and urinary tract. So it includes all disorders which are congenital disorders related to the kidney and urinary tract. Very good. Renal and urinary tract abnormality. What is the full form of CACUT? CACUT stands for congenital abnormalities of the kidney and urinary tract. Disorders such as congenital absence of kidneys, unilateral renal agenesis, bilateral renal agenesis, congenital cystic disorders of the kidneys, then disorders such as ectopic ureters, duplicated ureters, then disorders such as obstructions of the urinary tract. I told you about some obstructions of the urinary tract, such as uretropelvic junction obstructions, then uretroseals, then disorders such as vesicoureteric refluxes. They all come under congenital abnormalities of kidney and urinary tract, and these disorders are grouped under a term which is called as CACUT. Right? This again I have told in my classes. Coming to question number 23. Question number 23 says, a child recently had 2 episodes of gross hematuria. The mother of the child reported the child had throat infection. Now this again is throat infection about 3 weeks prior to the hematuria episodes. So about 3 weeks prior to the hematuria episode, the child had a throat infection. So there was a throat infection, and about 3 weeks after a throat infection, the child had hematuria. Now urine examination revealed RBC casts, which means blood is coming in urine, and the levels of C3 are low. So another important clue is levels of C3 are low. So 3 weeks after throat infection, hematuria has occurred. C3 levels are low. This clearly indicates that the child has a post-streptococcal, yes, most of you have given a correct answer, post-streptococcal glomerulonephritis. Now please understand that low C3 levels can be present in PSGN also, lupus nephritis also, and membranoproliferative glomerulonephritis also. MPGN is again, C option, is again something which can be associated with low C3 levels. But MPGN most commonly has a C3 level which persistently remains low for a long period of time. So we call it as persistent hypocomplementemia. If you see one of our statements, it says in our patient C3 was low and returned back to normal after 6 weeks. So this is one of the features of PSGN. In PSGN, the C3 levels remain low for about 6 weeks to 8 weeks, but then come back to normal in 6 to 8 weeks. So there is no persistently low C3 levels. Obviously, one clue that this is PSGN is that there is a history of throat infection, and 3 weeks after throat infection, there is hematuria. But another clue to whether this is PSGN or not is that the child had low C3 levels, and this low C3 levels are not persistently low. They have returned back to normal within 6 weeks. So if a C3 levels are low and return back to normal within 6 weeks, it is more likely to be PSGN. Membranoproliferative glomerulonephritis can also be associated with low C3 levels, but here C3 levels are persistently low. So we call it as persistent hypocomplementemia. Why IgA nephropathy will not be the answer here? Because in IgA nephropathy, within a period of 2 days, 1 day to 2 days, there is of a throat infection, there is hematuria. So there is a synpharyngitic hematuria. But in our case, the throat infection was 2 to 3 weeks prior to the hematuria episode. So again goes in favor of PSGN. Question number 24 says a baby delivered at 37 weeks through LSCS had an Apgar score of 6 and 7 at 1 and 5 minutes after birth. He developed tachypnea and nasal flaring about 10 to 20 minutes after birth. The baby has mild respiratory distress. So the baby has mild respiratory distress. So first clue is the baby is a almost a term baby, 37 weeks. Second clue, the baby was delivered by a cesarean section. Third clue is that the baby has some distress, which is mild respiratory distress, for 2 to 3 days, followed by gradual improvement. So the baby is improving also in 2 to 3 days. So all of this points out to the fact that the child most likely has which type of a disorder? This most likely has a, yes, what type of disorder it is? Term baby. I told you most common cause of respiratory distress in term and post-term babies is transient tachypnea of the newborn. Most common cause of respiratory distress in preterm babies, especially preterm babies born earlier than 34 weeks, is hyaline membrane disease or respiratory distress syndrome, the more commonly used term, respiratory distress syndrome. So in our patient, the child has transient tachypnea of the newborn because first term baby hai, 37 weeks, second delivered by cesarean section. Remember, why is there persistent fluid in these babies in the lungs? Because they are delivered by cesarean sections. Third clue is that these babies have a respiratory distress for only 2 to 3 days and that there is gradual improvement, which is why this condition is transient. In RDS, if you do not do anything or do not start treatment, there will be a gradual deterioration in symptoms mostly. Then RDS is mostly seen in children who have prematurity. But in our case, the patient is 34 weeks, the child is 34 weeks. Large opacities, option A, in both lung fields most likely goes in favor of pneumonias, congenital pneumonias. Option B, reticulogranular opacities, air bronchograms goes in favor of RDS, respiratory distress syndrome. Hyperinflated lungs, option C, hyperinflated lungs, atelectasis goes more in favor of babies having Meconium aspiration syndrome. It is option D, which is the X-ray feature of transient tachypnea of newborn. Everything is pointing out that transient tachypnea of newborn is the correct answer. Very good. So all of you have given the correct answer. And last question is, which of these milestones, again a question on milestones, is likely to be present in a 9-month-old child? So again you need to, I've discussed these milestones. When does a child start copying a line? Child starts copying a line from 2 years. When does a child starts making tower of 2 cubes? 15 months. When does a child start standing for the first time without any support? 12 months. And when does a child develops a pincer grasp? 9 months. A mature pincer grasp develops at 12 months, but a pincer grasp will start appearing at 9 months. So they are asking which of these milestones is likely to be present in a 9-month-old child. So obviously if the child is a 9-month-old child, the only milestone that is likely to be present is the pincer grasp. So pincer grasp is the correct answer. Most of you again have given A as the correct answer. So with this, I finish up my questions. 26th question is not required. I finished up my questions. Thank you again from Team Mist. Thank you again from my side. I hope you have found these topics useful. These topics were very helpful, would be very helpful for you if you go through these topics also and these questions also. I hope you have now gone through your second revision and you have now comfortably remembered the things that were discussed in the classes. At that time, everything was discussed in 2 days. But now I hope you are confident enough to be able to answer the questions in your exams. I thank you for attending this session. Wish you all the best for your exams. I want to see all of you successful in these exams. For different centers, please, I think Dr. Amit, Dr. Vineet will be the best people to ask these questions. As of this session, I thank you again and wish to see you all successful in these exams. Thank you very much and goodbye.